Hello to our listeners. My name is Beth Irias, and I am delighted to have Dr. Jaimee Arnoff back again. Jaimee had joined us previously for a conversation about self-harm and suicidal ideation. And I asked her back for a conversation today about working with caregivers when they have children or teenagers who are struggling with self-harm or suicidal ideation and how to respond to that themselves. Speaking as someone who worked with adolescents for a number of years, this is a very real thing that's happening in households, and it's a struggle sometimes for clinicians to know how to support families going through this. Thank you so much for joining us, Jaimee.
Thank you for having me.
For our listeners who are not familiar with you or your work, why don't you take a minute and tell them about yourself, and then we will dive into a very, I think, interesting and important topic.
Sure. I am a licensed clinical psychologist. I specialize in adolescents and young adults who present with depression and anxiety, many of whom also experience suicidal ideation and urges to self-harm. So I do that work therapeutically. I push into schools to talk to parents, school staff, and students about youth mental health and suicide prevention. I train other clinicians in the field on this topic. And then separately, I also do a lot of professional development, work within family court and other court systems for accessibility support. And I'm just happy to be here and to be talking about this topic.
Awesome. Thank you. The topic of suicidal ideation and self-harm is really scary for many of us. Obviously, the stakes quite literally couldn't be higher. And we know that a good number of us as clinicians will lose a client to suicide at some point during our career. So it's not like this is like, oh, it happens, but we shouldn't worry about it. Like, we should be worried about it. We need to take it seriously. And what I've heard from clinicians and what I've experienced myself is when you are working with a teenager who has, who's struggling with whatever struggle they have, sometimes they grab this card and they throw it down on the table and say, well, I'm going to do this to myself. And then a parent just freezes. And I'm just excited to hear from you because I've been in that position clinically. And it's like, what do we do? How do we conceptualize what's going on? And how do we support the parents to better support their child? And I'm saying parents, but of course, we're talking about caregivers, any kind of caregiver who's working with this child or adolescent, whether that's a family member or not. So let's establish that first. I say parents, but we're looking at caregivers. Jaimee, where do we start in this conversation? Because there's obviously so much to cover.
Right off the bat, I want to validate and normalize that experience for the clinicians that are coming into the room and potentially listening to this, feeling that way, because of course it is really scary. And so I do want to normalize that for clinicians, and I want to normalize that for parents as well. I think that's one of the most important priorities in working with a dynamic like this if it comes into your room, how to normalize the parents, the caregivers' emotional experience, also without centering their experience in the dynamic. I'm an adolescent psychologist. I primarily work with the adolescents individually, but the parent might be in the waiting room. The parent might be in the car picking them up. They're going home to those caregivers, to a household of individuals that for the other hours of the week, I'm maybe seeing them for 50, 60 minutes once a week. Like, that's who they're with. That is who's helping them regulate through these experiences, who's supporting them in these experiences. So, we want to normalize that. We want to empower them. And so reminding parents and clinicians that this is, one of the most intense things that you can experience. And it can be, related to feelings of fear, shame, resentment, if it's coming up in your office or at home, exhaustion of maybe having to manage this repeatedly if a child is making statements or if it feels like a threat of self-harm or suicidal ideation. And again, to really validate that these are all emotional responses that make sense in that situation. And it's really important to remind both clinicians but parents, for the purposes of today's talk, that they're not bad parents or bad caregivers or bad humans for having complex feelings in a crisis like this.
Thank you. I appreciate that. In the work I've done, what I've seen is caregivers just feeling so isolated and paralyzed, like not knowing what to do, feeling that terrible double bind sense where you're damned if you do and you're damned if you don't. And so you don't know what to do. Can we first start by talking about the etiology 101? Like, how did we get here? How does adolescent or young adult get to the point? And, obviously this is case by case, but how do we get to the point where we go, what I'm going to do? I am going to hurt myself and or I want to die. Whatever's going on in my life is so severe that this really seems like the best option available to me.
Yeah, I mean, it could be so many things. And I've been doing this work for over a decade. I think that to name one particular thing or even a collection of experiences sort of does a disservice to all of us because it could be anything. It could be persistent and severe depression or anxiety that is really impacting them day to day, or it could be a singular social situation where they felt embarrassed and they go home and they replay those moments over and over again, even if it was 1 or 2 seconds of their life, and feel like they cannot come back from this. And that's impacted by so many other things, like their mood in general, their temperament, family history, mental health history, if they're on medications, if there's substances involved. So many things can impact, a singular decision that an adolescent might make. And we have to remember that we're talking about adolescent brains as well. So they're not fully developed until now we know around, mid to late 20s, 27. So the brain is developing back to front. So the parts of the brain that are developed earlier are those more reactive, more emotional parts of the brain. The brain, and like that front area, that frontal lobe, prefrontal cortex, that's what we think about in terms of like executive functioning, organization, problem solving, like solution finding, thinking about consequences. So that is harder for them to utilize, for them to access in their regulation. They're more emotional, they're more reactive, they're more impulsive. And so we have to take all these things into consideration when we think about that question. How do we even get here?
Thank you. I appreciate that primer. And I appreciate you also pointing out that it can kind of, from a caregiver perspective, come out of the blue. And that's been my experience too, that there are some times where it's like you have a child who is experiencing generalized anxiety or who has had, a lot of trauma and change in their life. And so there were concerns about their mental health prior to this. And so then I guess it felt more like a progression of symptoms versus I've totally had the adolescent where it's like, what just happened? Like, we were coming in here for you to learn how to study better or whatever it is, like how to communicate more with us about how we support you in your studies. And then all of a sudden you're saying you want to die. Like, how did we get here? And so I appreciate you kind of pointing out sometimes we don't know. And it can be something really isolated. And also, it's been my experience too that parents can often internalize it as like it's something I did. It's something that I did. And if I had talked to my child differently, or if I had laid the groundwork in a different way, then we wouldn't be here now. And what I'm hearing you say is like, it's not that simple. Like there's a lot more going on here outside the adolescent and within the adolescent in their development that contributes to this being kind of the best solution that they're finding, whether that's self-harm or actual suicidal ideation or action. When I think about this, my brain goes back to a specific example where I was talking to a parent. Parent in this case had an adolescent who had anxiety, tended toward perfectionism, a lot of desire to perform and do well. And then it kind of got off track into the beginning of some NSSI, so non suicidal self injury. And then somewhere in there, as the months progressed, went to, I can't be alone. I'm going to hurt myself. And I remember talking to the parent and the parent saying, I can't leave her alone. I am afraid to go to work. I am afraid to pick up the phone and make a phone call about something. I am afraid to take a shower. Um, can you talk about that through your lens and your perspective and your work? Because there's just like this pretty rational hypervigilance that develops.
Absolutely. And I think one of the things that I consider with these caregivers within this dynamic is the parent's nervous system. Because, to your point, those words can affect them in certain ways. It could be that their own attachment wounds or trauma patterns are being triggered or activated, and that is leading to their dysregulation as well. And I always encourage them to seek out their own peer and professional support, separate from the child, separate from the work that we're doing together, because it does impact their life in a very pervasive way as well. Like not feeling like you can sleep in separate rooms, not feeling like they can go to the bathroom or to shower alone, not feel like they can go to work and miss part of their morning, or ensure that they get on the school bus or come home from school and are okay after school, or if they're not able to make it in school, like who's with them all day. And so, yeah, again, like really validating and normalizing that. In that case, I would also want to have a conversation with the caregiver and the adolescent about potential benefits for a higher level of care. If it's something where the caregiver doesn't feel able, or there's just more of a need to have supervision, could be 24/7, then perhaps even, a day treatment program or a partial hospitalization would be a good option to consider, as well as, giving them psychoeducation about what an adolescent inpatient unit would look like.
Yeah. Yeah. And Jaimee just used the word partial hospitalization. For our listeners who aren't familiar with that, it's this very formal language for something that is very simple, which is day treatment. PHP, partial hospitalization, refers to usually around 6 to 8 hours of treatment per day, usually 3 to 5 days per week. But even that, like in thinking about this from a level of care standpoint, having worked in different levels of care, that hole in treatment is also scary. So one thing, and there's so much to talk about in this topic here, but one of the things that I've seen is a child says it to a caregiver or parent or a teacher or coach or whoever. They find it in a diary or text message, whatever it is. Somehow the parent becomes aware that the child has expressed desire to end their own life, and the parent does what many parents would do, which is call 911, have their child assessed. And so then you have the emergency response team come out, and could be to school, which opens a whole nother layer of complexity of like, that's so embarrassing. Like now these people are showing up and there's a cop in my school and, whatnot. But so you have this assessment. Then how often does that actually result in a hospitalization? When you have a professional who is assessing them, who doesn't have a prior history with a child. But so let's say it does result in a hospitalization. So let's just talk about what that looks like. And Jaimee, I want to hear from you too. From my experience, one of the issues that we have is a major bed access issue. So are there even any beds in the city you're in the state that you're in, that can receive this adolescent for a psychiatric hospitalization? And if there aren't, then they might just be sitting in an ER. Then they get routed to an ER, or maybe you took them to the ER and they keep them there for a certain number of hours, a certain number of days, maybe start them on medication. But what I've experienced, and I want to kind of deconstruct this and also talk about it for any clinicians listening, is like, okay, so they're in this protected, controlled environment where they're under 24-hour monitoring. There are people around them all the time. And it's extremely difficult to step down into a residential treatment center. Is there one available? Can you get the insurance authorization? Do you even have insurance to afford it? If you don't, how in the world are you going to pay for it? Like there are all these access issues. So then often they step down into partial hospitalization or outpatient treatment, which means that child is still mostly at home and they're going to treatment for a couple hours up to 8 hours per day, but not every day. Can you speak to that? Because it's like there's the perfect world of how this would go.
Sure.
And then there's the reality. You have seen this more than I have, but can you talk about that kind of part of it? Because I think that also contributes to this very real fear the parents have, where it's like, my child said this thing 2 days ago. You're telling me now my child is safe to be home. And just, you're going to have an intake next Tuesday when it's currently like a Sunday afternoon. So, like, great, I need to get them through the next 9 days and they're not going to hurt themselves. How in the world am I supposed to do that? And you're nodding, like, just for our listeners. Jaimee is like nodding while I'm talking. So take the mic, go, please go talk about that.
So much to talk about. I mean, I'm in the Hudson Valley of New York. I currently am in Beacon. We're lucky enough about 30 minutes away to have a stabilization center in Dutchess County. So that's an all access 24/7, 365 mental health and substance use sort of clinic that you can go to, have an evaluation if you're expressing suicidal ideation, and they can hold you for up to 24 hours, which sometimes when we think about statistics for deliberation between I'm having this intrusive thought to I'm going to take action on this thought, not a lot of time. So sometimes 24 hours is all that we need just to be stabilized. And to your point, there might be some medication management introduced. They may have access to some other clinicians that are new or different or more effective or just feeling helpful in that moment. But if you go to the stabilization center and report intent and plan, then they can't hold you at the stabilization center. And there are no local adolescent or child inpatient units in my area. They have to drive at least 45 to 60 minutes to add to all of what you just said, the parent in a moment of crisis might have to transport their child or adolescent an hour in a car, which is dangerous, a moving vehicle from someone who's thinking of hurting themselves, may not be stable, can be dangerous for the adolescent, the caregivers who are driving, other individuals in that car, other individuals in the car surrounding that car. It's very complicated. It's very difficult. It feels unfair. It's something that I think a lot of local clinicians in my area, but to your point, across the United States, the world, are frustrated with, because there just are not resources for these kids. And it would be, I think, ineffective and probably a little scary for an adolescent to be placed in a local adult unit. And so, yeah, they do sort of get placed in these step down partial day treatment programs, intensive outpatient. So they're maybe seeing their clinician a few times a week, but still for much less time than they would at a partial or day treatment program. They might be trying to reintegrate them back into school. Also, people might be checking up on these adolescents and asking them the questions, but they learn pretty quickly what the quote unquote right answer is to avoid waiting in a hospital emergency room, being transported to an adolescent inpatient unit. They're not having a good time when they're there. They want to come home. They want to go back to school for a variety of different reasons. They want to see their, therapist that they've been with for years, and they will give the answers that they know will get them sent home. They're not, they know what they're doing. They're very smart. And they'll tell me that. Like, when I ask them those questions and I ask them, let's talk about higher levels of care in session. What do we think about returning to partial, or do we need a more intensive outpatient? Do we need to go back to that inpatient unit? They'll say, if you or mom or dad or whoever else is in the home calls and sends me there, I'll just tell them I'm not having those thoughts. Or, yeah, I had them for a minute. They were gone. I was having a bad day. They know what to say. And so that's even more scary. And that's why, in moments of crisis at home with these parents, it's required to take it seriously, because we really don't know what they're utilizing that statement for. And to your earlier point, just like a maladaptive response to intense emotional dysregulation. But if they are saying that they do feel suicidal, that they are having these urges to self harm, there has to be a call made, because we want to make sure that they are taken care of, but also that we're going to take it seriously and we're going to respond as though this is what's going to happen next. Because sometimes parents come in and say, they keep threatening this when I say no to something they want, refuse to give them something that they would like, when the day doesn't go their way, and they think that it's, a way to change the response or get something that they might want that for them might be what they feel like they need to regulate or self-soothe. But they need to learn that that's a serious statement. Like, if they make those statements to us, we are going to call for help because we want to make sure that they're safe.
In thinking about this level of care piece, I think this element that we're discussing, I think, is one of the most initially critical pieces with parents, because it's absolutely been my experience that you have a child who's, we'll say, not in the system, and then something happens and then they are quote unquote in the system, whatever that thing is. And there's an expectation by a caregiver of like, okay, I've now gotten my child to this inpatient bed. Let's say it's a 72-hour hold. So I know that they're safe for the next 72 hours and the clinical team is going to be assessing them and someone's going to help me along the way. And yeah, you just took a deep breath because, like, well, in a perfect world, yes. However, what can absolutely happen is, okay, here's your child, here are their belongings, here's a list of referrals, good luck to you. And then a parent going kind of like, what do you mean? What do I do now? And if that child doesn't already have a therapist or, like an available school counselor, whoever it is to help guide you, you have a parent that's sitting there kind of going, oh my God, like, where do I start? And I'm also worried my child's going to hurt themselves. So I kind of appreciate the psychoed piece there of, let me tell a parent this is how this might go. There's the perfect world and then there's the reality. And my goodness, like, I remember a situation in LA County and Los Angeles County where there were not beds available, and the parent was taking a child from facility to facility to facility, and another parent at home trying to call. And it was just like this huge, unbelievably stressful mess because of the holes in the system. And then you get to that piece of like, how seriously does a parent take this? You and I talked about it before we started recording. One thing I've certainly heard from parents is like, well, my child is just doing this to get attention, or they're just trying to manipulate me to letting them go to the party or whatever it is. Can you expand a bit? Like, I want to take a little jaunt over into some statistics here. Can you expand a bit on the risk of completed suicide, of someone actually dying by suicide? How often is it because did someone say something to somebody else that they were intending to die by suicide? Or is it something that is completely unpredictable? Is it preventable? Can you speak a little bit to that? And I know I'm veering into our prior conversation when we were talking about, exclusively suicide and self-harm and not necessarily this parent and caregiving piece, but I think kind of laying the groundwork, because it's hard to sort through how realistic of a risk is there right now to my child.
Yeah, I mean, it is suicide completion is the second leading cause of death for elementary to high school age children, and third leading cause of death to like college age young adults. And so this is prevalent. The statistics are significant. And I know I mentioned earlier deliberation data. So the time between having the thought of, I want to hurt myself, I want to take action, whether it's suicidal action, self-injurious behavior, that can be and typically is as small a window as 5 to 10 minutes. And so that's really quick. And that's when some people might say, like, oh, this is an impulsive decision, because it happens so quickly. And that ties into, which I think we would have talked about earlier, the importance of means restriction and psychoeducation with adolescents and their caregivers on minimizing access to means for any sort of harm, especially if the adolescent has identified particular objects that they think about when they have these thoughts. Like, is there imagery? Are there particular objects that they have in mind? Whether that's something sharp, like a razor or a kitchen knife, medication, whether it's their medication or medication that they know that they have at home, rope, belts, anything. And, I have conversations with people about this all the time. If a person is having this ideation, they have a plan, they have intent, they will find an object, right? But if they're a teenager who may or may not have access to a car and they have a curfew of like, no, I'm going to watch you walk out the door, or no, you can't go out with your friends until this late. They're at home. What can be done in the home with like a lockbox or a firearm safety storage, that within those 5 to 10 minutes of I'm having this really deep, intense thought, I want to do something, I need to hurt myself, to let me find that object. Oh, I have access to it, I'm going to use it in those 5 to 10 minutes. Once you sort of surpass that 10-minute mark, the likelihood that the urge is as severe, as intense, as frequent, lasts as long, significantly reduces. And so if it takes them 5 to 10 minutes to find the lockbox, figure out what the code is, get access to the key that unlocks it. If it's a firearm, I always recommend storing the firearm itself and the ammunition separately. So sure, maybe in 10 minutes they can find the box, unlock it, which feels unlikely. It's going to take them longer than that to get to part of what they need. But if it's stored separately, they can't fire something off if there's no ammunition. They can't take ammunition and do something with it if they don't have the firearm. So we're wanting to, safety plan as much as possible with the statistics that we know, apply to this population.
Thank you. And thank you for integrating that piece about means access and also how it fits into that initial urge. It's a precarious position for a caregiver and also even for a clinician. Like, speaking as someone who's totally done risk assessments for adolescents and not as an emergency response team professional. And then like for the people listening that do that, of like, whoo, like that's a lot of information to take in and try to make a cohesive decision about the next move. Like, imagine parents trying to do that don't have all of this training. That's a tough spot for them to be in. Those statistics about the rates of young people dying by suicide, I know for me, it just makes my heart turn sideways and kind of sucks the air out of my lungs. Parents are not wrong to be concerned about this. There's so much here to unpack in households where there are multiple parents or caregivers. One thing I've seen is like kind of disagreement between caregivers about how you respond to it. If a child is making these statements or has a history of self-harm. Jaimee, does a history of self-harm, of actual harm to one's body, make an adolescent higher risk for dying by suicide?
Yes, but it does not mean that that person will at any point take action to take their own life.
Thank you. Thank you for that. And I think part of it here is like wanting to empower ourselves clinically with this information so that we can be using it for our own decision making. But so you have a parent who has this child that right now the best solution is, I'm going to go do XYZ, insert use of means here. And to your point, it's absolutely been my experience working with high acuity adolescents. Yeah, means are available. Like, if you have a shoelace, like, so That said, like, we can do our best to try to restrict means, to lock up knives, to be mindful about belts, to obviously firearms, things like that. Um, that said, when you have this parent who is paralyzed because they don't know what to do, what are some of the absolutely don't do this and here are some good options for you that we can give to parents to kind of help coach them, because chances are these things are not happening in our office. This is something that's happening on a Saturday afternoon after soccer practice, and all of a sudden this whole situation escalates and a parent's going, what do I do now? And they may not have an on-call therapist and be like, here's what you say.
Yeah, absolutely. There's certainly some common loops that form, like communication loops and behavioral loops that form in a parent's, just like a caregiver child dynamic when there's been a statement of wanting to hurt themselves. So it's really important, again, for the parents to understand and reframe for themselves that these statements made by their children is just externalized inner chaos. It's not always conscious, but it is an SOS in a way. They're trying to make the person see how badly they feel. They just don't know any other way to communicate that. If they've gotten attention in that way, attention, relief, concession, if they're trying to get something or change something, that sort of forms a behavioral loop. It's not out of manipulation. It's just that crisis is promoting connection in that way. And so if a better way to respond might be a parent saying something like, okay, I hear you. I'm not leaving you alone in this. I'm taking what you say very seriously. So I'm going to stay with you here and we're going to get support. When I'm scared, I'm going to seek help for us in this dynamic. And that's not to punish you. That's to protect you. And then, it's letting them know that in those moments there are other options. And so allowing parents to sort of co-regulate with their children in those moments. So letting them review the safety plan, asking, okay, well, we have Dr. Jaimee's safety plan. Should we review it in this moment? Like, clearly we are in crisis, right? And I'm here with you. And let's figure out what we can do in this moment while we're taking a pause before any other, determinations are made, or while we wait for help. We can review a safety plan. We can just sit together and not talk and breathe. We can go for a walk. We can write something down. We can color, watch TV, so many options. And I would be wanting to go through these options with all caregivers when there's first a mention of suicidal ideation or urges to self-harm in session, to make sure we're all sort of grounded in the safety plan. And to your earlier point, if caregivers disagree, that we are in some agreement, even if it's not a caregiver's, preference or priority of how we would, take steps to handle the crisis. In those moments, it's been predetermined. This is what we're going to do. And then if there's some feedback on how that worked or how they felt or how they clashed or how they were able to come together, that's another thing that's worth processing with parents separately. And then also potentially as a family dynamic, if warranted, case by case specific, but you would want to have that sort of predetermined. So in the crisis is not the moment where caregivers are deciding how they're going to respond. They just know what they're going to do. They feel validated and empowered by us as clinicians to do it. And that the adolescents also know what to expect. Whether or not that curbs their urge to make those statements out loud in moments of crisis, sometimes they're so overwhelmed. It's not like a conscious strategy. It's not like a calculated power move that they're making in these moments, just deep emotional dysregulation. But I will provide psychoeducation in session with adolescents only about this is what happens when you make a statement of suicidal ideation or you're expressing urges to self-harm. This is who will be called, what the process will be like, to go back to your earlier discussion, how long a process it can be, like that they might be waiting in an emergency room in a hospital that they for sure will never be accepted into because of their age for a full day, multiple days. How they'll have to be transported to somewhere that's far away where their parents, their friends don't have access to them. The realities of what those statements mean, because they might not know. This might be an understanding that they've pulled from media, movies, TV shows, books, friends that had different experiences, or maybe were coming from other areas. It's important for the adolescent to also understand what the process is like so that everyone is informed to respond in the moment in these crises.
I'm thinking about the statement you had made about kind of internal chaos. And it sounds like part of it for the caregiver is needing to translate. So when there's a statement of, I'm going to run away and I'm going to go kill myself, yes, there's that statement and we need to respond to that and take it seriously. And also the meta communication there is, I am in insufferable pain. I'm imagining the intensity of these moments of a parent's fear, and knowing that sometimes these moments escalate very quickly. That the teen makes a run for the gardening scissors and shears. That bookend that is heavy and has sharp edges makes a very good weapon, that this can really kind of turn on a dime. How do you work with parents to try to stay regulated? Because it's terrifying.
Yeah. Again, tap into their own potential activation and let them know that could be contributing to the dysregulation, normalizing that this experience is very overwhelming. Help them learn how to sort of pause before responding. So more responsiveness rather than reactiveness. But I also want to give parents permission to be steady in these moments and not perfect, because there's no way for us to predict, to your point, what's going to lead to that moment and what's going to happen next, regardless of the caregiver response. Even if we can curate that perfectly and agree on it in a session and it's documented on a safety plan, like we actually don't know what will happen in those moments, and how the dynamic will communicate with one another. So validating for the caregivers that a regulated parent isn't one that never reacts. We always use the sort of motto of responsiveness over reactivity, but it's not that a regulated parent never reacts. Of course they're going to react. We can't help it. We're human beings. It's just understanding how to return to calm and repair when needed. So giving those, validating statements to an adolescent, regulating themselves by grounding, taking a deep breath before they respond, utilizing that, peer or professional support. I sort of give them like a 1, 2, 3 summary of what to do in those moments so they can validate the feeling, not the behavior. So saying something like, kiddo, I can see that you're really upset right now. I know this feels like a lot. And that's acknowledging pain without rewarding the outburst or the statement. And it keeps connection open. It's sort of like bringing them together. Clear safety message. When you talk about hurting yourself, I'm going to take that really seriously, right? So that means that we're going to call Jaimee, call in my area, Dutchess County Helpline, which connects to the stabilization center, call 911, call the intake coordinator at such and such a placement. Separate of that, I have a list of all of the local places with the admissions numbers, intake counselors that they can have access to if they want to. We have cards with the Dutchess County Helpline, which connects to the stabilization center. My kids are usually like sliding those into their wallet or between their phones and their phone covers. Like they're carrying them around, their pocket size, and parents can do that as well. But letting the adolescent know, like, your safety means more than anything. And so it lets them know that in the face of those statements, there's going to be structure and there's going to be love. There isn't going to be bargaining. It might be overwhelming, but like there's not going to be panic. And then any sort of boundary, but do it warmly. So if it's because they want to change something, the adolescent wants something that to be different, wants to change something, I'm not going to be changing the decision that I made. And I love you and I'm here with you. But the situation stands, and that sort of prevents that reinforcement of those coercive loops that I talked about earlier, and sort of maintains that attachment between the dynamics.
You've mentioned safety plans. That in and of itself could be its own hour-long episode. And I certainly encourage our listeners. We have a number of episodes talking about death by suicide and non-suicidal self-injury, and I encourage you to listen to those. Of course, the first time, chances are we're not going to have a safety plan. Like, I don't think many parents are like, okay, like I got my kid's vaccination history and also a safety plan here in case they threaten to hurt themselves. So something probably happened that got us to the point of writing a safety plan. How do you involve the teen in that? Or is this generally something that's happening like with a parent by themselves? Like what is the best case scenario? Obviously dependent on the kiddo and the situation, but what is kind of the best case scenario for you?
I guess if it's a safety plan in general, I'm always involving the adolescent because I want to empower them to feel a part of the plan and to be able to contribute what it is that they're experiencing, what has typically helped, what has typically made the situation worse. Promote that sort of internal locus of control. A lot of this is the adolescent just trying to feel in control of something, not necessarily like trying to control the situation or a person. It's just like, I feel no control. What can I like place control onto in this moment of crisis? So I'm certainly involving the adolescent in the, original safety plan, which is what's happening pretty much in the first session of me meeting a client, because I've asked the questions beforehand of, whether I'm talking to the adolescent or the caregiver before making our first appointment of, is this something that's ever come up for you? So I have a general idea. But sometimes the caregiver doesn't know, and then it comes up in session, or the adolescent may have lied at some point, and then it comes up in session or comes up later when they're not with me. But we're still sort of preparing for those moments. And then with the caregivers, I think even if I were to do the safety plan for them in a parent only or a caregiver only session, I would still let the caregivers know that in the following session, if this was not done like as a family unit, I would be bringing that safety plan to the adolescent to review it so that they know what's going to happen as well. And it's not more dysregulating to have these steps be taken. Like they're already prepared. It's just sort of following a structure that maybe they were so overwhelmed they couldn't sort of initiate themselves. And adolescents don't want things to happen without them, especially within a therapeutic relationship. Like, of course, there's some of my clients that would rather do anything other. They'd rather do homework than sit with me and their caregivers in a session. That's their worst nightmare. Like they're like, have at it, have the parent only session. I don't care. I don't want to be involved. And then but a majority of my adolescents are like, you will not speak to my caregivers without me present. I need to know who says what their faces look like, what their tone is. I don't want to be talked about like when I'm not there. So just like I would invite caregivers to review an adolescent safety plan during the session before I send them home together, I would certainly bring the caregiver safety plan into the session with the adolescent so that they are feeling a part of it. And again, it's promoting that open communication. It's preserving the attachment dynamic. This is happening to them together in that moment.
In this loop that can develop where kind of the stakes keep getting higher, and maybe not to this extreme, but I laugh. It's like, what parent has not been involved in that loop? Like no matter what your parenting strategy is, you're going to have moments where you find yourself in that loop where it escalates, where then you're like negotiating and it spins out of control. Not that I speak from experience or anything like that. But when parents are in that loop, it sounds like part of it from a psychoeducation standpoint is helping the parent recognize like really this intense desire, this solution, if you will, for this immense pain is generally pretty short-lived. Like we need to wrap around the child for that 10, 15, 20 minutes, whatever it is, like just to kind of bring their nervous system back into some kind of regulation. And in my mind, I'm like hearing the Gottmans talking about flooding and like once like frontal lobe is offline and limbic system is just running the show. Like how do we kind of walk it back? I'm curious. One of the things that I've seen happen, and again, this is, I think, a function of the system, if you will. I am not going to go to school. You can't make me go to school. If you make me go to school, I will go into the bathroom and I will cut. I will hurt myself. I'm just creating this little case study for you, this little vignette. Parent comes in, says, I cannot leave my child alone. I guess I'm going to start homeschooling them because they're saying if I send them to school, they're going to hurt themselves. Take the mic, Dr. Jaimee Arnoff. What are you doing in that situation? And I'm just so curious, like, because that's one of the times where like the stakes are really high. And I'm just so curious of like, where do you go first? And again, case by case, but where do you go in that situation?
And I'm with the caregivers.
Let's say you're with everybody. Or if you want to take the kiddo out of it, take kiddo out of it. I'm just super curious because I've been in those clinical situations where I'm like, oh crap, now I'm in too. I don't know what to do right now.
Well, here's the best part of that. I'm with you. And that's sometimes really scary to hear from other clinicians who are like, but you're an expert on this topic. What do you mean? And I'm like, it's scary for me too. Like, I'm also sweating when that happens in session. And even though I've done this a million times and I train people on this is what I mean. I love this. I ask for those clients. I'm like, please send them to me. I still have to confirm with my colleagues and my like therapist friends that I did okay and I didn't forget anything or do something wrong. These are high stakes. So we want to be doing our best. Ultimately, as clinicians, we want to be supporting these families. And this is hard. I call it tough stuff. This is the tough stuff, the toughest stuff. With the parents, I want to remind them, I use the airplane oxygen metaphor, you have to put the oxygen mask on yourself before you place the oxygen mask on the adolescent next to you, right? We need to make sure that you take a pause, that you are being thoughtful about what's happening, and that's where sort of all this psychoeducation and understanding about what the teen is actually going through in those moments can come in handy, because the adolescent is dysregulated. They do not know how to regulate. That's why they're making these statements. That's why they're jumping to this thing. And adolescents are sometimes mirroring or absorbing regulation from the adult or the other individual that's with them in that moment. So if you are working to regulate yourself, and that those are things that the caregivers and I can talk about in parent only or family sessions, the adolescents can, it can be sort of an attachment opportunity, because the adolescent can say, hey, guys, this is what I do when I'm feeling dysregulated. This really helps me. This is something Dr. Jaimee has taught me that I really like. Maybe I can prompt you through some of those things. You can prompt me through some of those things, and we can figure out what works for us, individually as a dynamic. Obviously, I'm still advocating for the caregivers to have their own support. But again, we have to take these statements seriously. And so if that is the coping mechanism that the adolescent is offering in that moment, then perhaps they do need to be evaluated to determine if being at home, going to a typical 7:30 a.m. to 2:30 p.m. school environment is what is right for them. And the adolescent can be informed on, well, there are day treatment programs where you can go for this many days a week. You'll come home, but there's partial focus on academics and partial focus on mental health. You'll have some time to do your work, but likely you won't have as much time as you normally would in school to do your work. And sometimes that, is a wake up call for the adolescents of, oh, I don't want to fall behind. I don't want to miss out on, social opportunities with my friends or my sports or my clubs. Same thing with partial hospitalization. That tends to be a little bit longer during the week, hours during the day, and also even less of a focus on academics and more of a focus on mental health. And then there's an opportunity for them to potentially not have access to those things and to just be placed in an inpatient unit where they're not going to be coming home. So, what's really going on? I think it's just a good opportunity for them to ask more questions, to be curious, to work on regulating themselves so that they can co-regulate with their adolescent and figure out what is the barrier to you getting to school today. If this is the response to, if you don't let me stay home from school, what's going on at school? What is happening that's causing this response in an effort to stay home? Because that's going to be the bottom line. Can we figure that out? Can we address that issue so that you don't have to resort to statements like that or have thoughts like that of, if I have to go to this place and can't leave my safe place, which is, in a nice way, the adolescent is identifying home. What's going on?
You've said a couple of times kind of not being afraid to take steps for safety. And, in this case, often calling 911 or emergency response team or, whatever kind of services you have in your area. A teen then learns, because that's quite a process. And depending where you are, that might mean you're getting the whole wee wee ambulance showing up. Depending where you are, I've had fire department show up. It's sometimes it is a thing. This is not some quiet thing that happened where someone in an unmarked vehicle drives up and knocks quietly on your door. That's not always how that one goes down. So also let parents know that, let a teen know that. But so these super intense situations, and so I'm imagining part of that response of fine, then I'm going to pull out my phone. I'm going to call 911. We're not just supporting parents and doing that. We're doing that ourselves, and reinforcing that as clinicians. We have that responsibility too. So we do that thing. And then let's say the child does not ultimately get hospitalized. I really appreciate the angle you're coming from in the importance of the emotional dysregulation piece, because then I'm seeing basically here is this, behavior, this coping mechanism that's attempting to solve this problem. And it may on some level get some needs met, but can we try to swoop in there and replace it with a safer, healthier behavior? And obviously best case scenarios, you have a mental health professional involved in that. But then also I'm hearing empowering the parents, where it's okay, basically we need to get you, my little love, we need to get you through the next 10 minutes. When this is so acute and so horrible, you're crawling out of your skin, let's go get some ice cream or whatever it is. Because they are very intense moments. And I, like Dr. Arnoff, I've been in those situations with teens where it's just oh shit. This is getting really the kitchen is getting hot and scary very fast. It sounds like from our conversation, the most important takeaways are psychoeducation, not just for the caregivers, but also for the adolescent themselves. And I'm also guessing for the system as a whole. So if you have a school counselor involved, a teacher, whatever it is, to be this is what's going on, at our kitchen table, let me tell you what we're doing about it. And then beyond that, really working with the parents to have their own services and opportunities for regulation so they can try and co-regulate with their kiddo. And one of my other big takeaways is don't be afraid to pick up the phone and call emergency services and let them do their jobs. What am I missing? Or are those like really kind of like the biggest takeaways from this conversation today? Because I know, at least for me in these moments, like there's so many times in my life that I like do the training, like whether that's first aid or um, lifeguard or whatever it is. And you're like, hey, this is all well and good when things are calm. But when push comes to shove and like the bad thing happens, how do I make this as simple as possible so that I remember what to do? Um, is there anything that I'm missing? Is this like I'm kind of like thinking to myself, like, clinicians, get out your post-it note, write these down right now so that when you're like, oh my God, it's happening, you're going to remember what to do.
Yes. We want to help parents, caregivers, see that this behavior is a symptom, not a strategy. So if the caregiver sees this behavior as coercive or manipulative or threatening, there might be retaliation, there might just be complete disengagement. And we want to help them stay out of this narrative that the adolescent is using them in some way and focus on this reframe that they're really just being called to co-regulate with these kiddos who are in pain and in crisis and they just don't know what to do.
You're just full of little quotey quotes right there. There are a couple of really good ones you just pulled out. Thank you for that.
Thank you.
For our listeners who want to learn more about you and your work, Dr. Jaimee, what's the best way to do that?
Yeah, they can go to our website, bfftherapy.com, learn about what we're doing. I consult with lots of clinicians on this topic. Our Instagram at BFF Therapy, we're posting things and have a link tree of all kinds of courses and things that they have access to that they can learn more from myself and what I like to talk about and just my experience working with this population. Because again, it's tough stuff. So I'm always also, empowering clinicians to feel comfortable referring a client who is experiencing suicidal ideation or urges to self-harm to refer them out to a clinician who feels more comfortable or maybe specializes in this topic, and to see that not as a failure, but as sort of the ultimate way to support that client by recognizing that that's just not what we feel competent in or even just have the capacity for. As someone who specializes in this, I don't necessarily have the capacity to only have high-risk clients, and that's okay. I can still talk to this family, see them once if that feels helpful, and have an honest conversation, giving some of this information, but also providing a list of resources of other clinicians that are open and available.
Awesome. Thank you. I think it's a really good point. And I'm guessing in terms of resources for clinicians beyond the ones that you've just mentioned, it sounds like one of the most valuable things a clinician could do is empower themselves in advance to know who they call.
Yes.
Like who in your county do you need to reach out to? And like, where are the local hospitals? And like just to have that at the ready.
Exactly.
As a preventative measure.
Yes. I mean, 988 is the national suicide hotline number, but I would certainly recommend clinicians look up if there are any child or adolescent specific partial day treatment programs or inpatient units and sort of have the name, the address, and typically they have contact information for intake or admissions coordinators with like a number that usually the parents can call and initiate themselves. If they need to loop the clinician in, they can do that as well, and like have them provide supplementary paperwork and information. But to have that sort of on hand and just like copies that you can either hand out or email or send through the portal or whatever it is that you're using.
Awesome. Thank you, Jaimee. Again, for our listeners, we've had the pleasure to hear from Dr. Jaimee Arnoff. You've given me particularly a lot to think about, and I really appreciate particularly the framing of like kind of breaking the habit of, I guess, personalizing something that really is not personal for us as a clinician or caregiver. It's someone who is in extreme pain doing their best to figure out a way to make it stop. So how do we help them? It is always a delight to have you Thank you so much for coming on and for sharing your expertise with us.
Thank you for having me.